Good afternoon, everyone, or good morning, or good evening, depending on where you're joining us from. I'm Dr. Tom Frieden, President and Chief Executive Officer of Resolve to Save Lives, an initiative of Vital Strategies. We're delighted to be hosting this meeting to focus on three key interventions that can be rapidly scaled up to save lives. We have a simple equation at Resolve to Save Lives that 50 plus 30 plus 0 equals 100. That means if we can get to 50% blood pressure control from the global 14% rate, if we can reduce sodium consumption by 30% and get to 0 grams of trans fat, we can together as a world save 100 million lives over the 30 following years. As you know, cardiovascular disease is the leading cause of death in the world. It accounts for about 1 in every 3 deaths, and most of these deaths are preventable with resources, with tools, with technologies that we have today. We're failing not to find new exciting discoveries, although we hope for those. We're failing to implement what works effectively. And these are the 3 areas where we're working. The first to be discussed will be hypertension control. There are about 1.4 billion people in the world who have high blood pressure. Only 1 in 7 of them have it under control. As a result, more than 10 million people a year die from hypertension. That's more people than die from all infectious disease combined. And although in the wealthier countries of the world, treatment of hypertension has been the standard of care for more than half a century, it is still a rare exception rather than the rule in most of the world, which accounts for most of the preventable deaths. I would also say that in this year of focus on universal health coverage or universal health care, UHC, I fear that it will be like health for all, a big slogan that doesn't result in big progress. Hypertension is a crucial indicator and crucial intervention. Treating high blood pressure in adults will save more lives than any other primary care intervention among adults. And in addition, doing so will improve the primary care system. As you'll see from today's talks, to do hypertension right requires a responsive primary care system. The second area that will be discussed is sodium, which is a leading cause of hypertension and premature deaths. There's a clear relation between sodium, blood pressure, and mortality. There is not an easy route to reduction of sodium, but doing so has a major benefit, both in terms of economic savings and, most importantly, lives saved. World Health Organization estimates that for every $1 invested in sodium reduction, as many as $19 can be saved from social and economic costs. And the third panel will be on trans fat. Artificial trans fat kills more than 500,000 people a year around the world. It's a toxic chemical. There's no reason for it to be in our food supply. It can be removed without changing the cost or taste or availability of great food, and only your heart will know the difference. When the world does this, it will be the first non-communicable elimination program. We have the eradication of smallpox. We're close on guinea worm and polio, but in the non-communicable diseases, this is the first area where we're trying for an elimination program. And we're seeing real momentum from the European Union, from Thailand, which is a real leader in this area and deserves a lot of credit, both on the UHC, actually on all 3 of the areas, real progress in Thailand. So it's an honor and a privilege to be here, and I look forward to learning from our Thai colleagues. Working together as a community, we think we can help save those 100 million lives. At Resolve to Save Lives, we have principle of the 3 S's, simplicity, speed, and scale, that we work with partners to establish pragmatic, simple approaches, then to rapidly scale them up because lives really are at stake. It's critical that we continue to use information to improve performance. None of us has all the answers. We all implement programs which could always be improved. So it's in all of our best interest to learn from the work that we're doing and others are doing so we can continuously improve the programs. The purpose of today's session is for all of us to learn from people working on the front lines, to have an interchange of information and experiences, to see how we can work together. And we're delighted to do this under the rubric of linkscommunity.org. LINKS is a partnership among multiple organizations to build and grow the cardiovascular prevention community. I encourage anyone who hasn't yet joined LINKS community to do so. We have availability of free technical assistance, and most importantly, the opportunity to share information among partners as we're doing right now. So and we are broadcasting this to the LINKS community through a live web stream. So without taking up more time from our panelists and this important discussion, thank you and welcome.
Thank you, Dr. Frieden. And can I have my slides up here? So what I'd like to, oh yes, perfect, thank you. Well, thank you, Dr. Frieden. And I'd like to welcome everyone to the hypertension section, which will be starting shortly. My name is Mark Jaffe. I'm the Senior Vice President for Resolve to Save Lives. And next slide, please. As Dr. Frieden mentioned, that to improve cardiovascular health, we're going to be focusing on improving hypertension control from 15 to 50% worldwide. We're going to reduce salt consumption by 30%, and we're going to eliminate artificial trans fat. Next slide. So when we think about hypertension, which is the focus of the first panel, it kills more people than any other condition, approximately 10 million deaths per year. But the good news is that hypertension can be effectively controlled. We have the solutions, and I'm hoping today we'll start to unravel some of the early successes and the early strategies to figure out how to move from the knowledge about how to do it to actual implementation, implementability. So we'll highlight in this panel discussion how health providers across different healthcare systems in different countries are working to address hypertension using the World Health Organization HEART's technical package as a framework. Next slide. So in order to address hypertension control, when you look across the effective evidence that demonstrates how to do it, you can segment it into 5 different categories. And this is very, very similar to the to many other published many other things that have been published. Number 1, an evidence-based protocol, which is more than a guideline. A guideline is a big, heavy book with lots and lots of pages, and a protocol is something very simple and straightforward with very easy steps, which is evidence-based that almost anyone can do with some medical training. And if you have an evidence-based protocol, then the next 4 steps logically follow. If you have a simple protocol, then it's much easier to get an adequate medication supply, because as opposed to dozens and dozens and dozens of options, there's a finite number of options, just maybe a handful number of drugs, which allow you to work on logistics and to secure adequate pricing for medications. And if you have an effective evidence-based protocol and you have access to medications which are affordable and effective, then you can have community-based treatment. You can get the care closer to your home. You don't have to go to a faraway district hospital or to a specialist. You can get the care by someone on your team, perhaps someone who isn't a physician, and it can be very close by. Also, patient-centered care can occur because now you don't have to travel quite so far. You can get care which is convenient. It can be perhaps even something as simple as having a longer supply of medications as opposed to a fortnight of medications, maybe 20 or, maybe 30 days, maybe 100 days of medications. And lastly, in order for all this to work, the glue that holds us all together are effective information systems. Because if you have a simple protocol, you have access to a standard set of medications, if you've got care happening in the community by physicians and non-physicians, you have patient-centered care, then those are some very, very concrete things that you can measure and track. And you can see how well you're doing as a system, and you can also, just as important, find out which individuals in that system need a little more attention and help. So with these 5 core components can make a big difference in hypertension control. Next slide. So the objectives are to provide tools and proven strategies to improve cardiovascular health at the country level, to highlight the successes and lessons learned from the field in the areas of hypertension treatment, salt reduction, and trans fat elimination, and to inspire action to address cardiovascular diseases, the world's leading cause of death. Next slide. So on the panel, I'm happy to be present here with Chasiri Angukawaranan, a lecturer from right here in Thailand, Dr. Prabdeep Kaur, head of the Division of NCD's Indian Council of Medical Research in India, and Anyapam Pathney, senior consultant for Cardiovascular Health, Resolve to Save Lives Initiative of Vital Strategies India. Next slide. So with that, I'll pass it to the first presenter.
Thank you very much, and thank you very much for having me. Again, my name is Chaisri, and I'm a family physician. And last year, we conducted a rapid assessment survey of hypertension treatment in Thailand. Yes, I'm sorry, I cannot hear very well today because I have a cold and I flew this morning. So I don't know what my voice level is. So if you can't hear me, just yeah, it's not working. Yeah, so good. Okay, thank you. So the study was conducted in partnership with the Ministry of Public Health here in Thailand and also the Bureau office in Thailand as well. Next slide, please. So some background, like initially said, in Thailand we have about 13 million patients, and about 30% of these 13 million patients are actually under control. Our study assessed, we know that 70% of hypertensive patients who are receiving care are getting treatment in government hospitals. So we assessed how they have adhered to treatment according to Thai treatment guidelines in the national government hospitals in Thailand. Next slide, please. So here we actually did a couple of things. We did staff interviews, we did structure interviews, but mostly today we would like to highlight the protocol, the hypertension audit protocol that we conducted on 1,400 newly diagnosed patients. This data was collected from 4 provinces. In each provinces, we selected 4 hospitals, 1 provincial, 1 large size hospitals, and 2 small size hospitals. So 16 hospitals in total of 1,400 new hypertensive patients. Next slide, please. So here, just to give an overview as well about our hypertension treatment, that we do give refills and non-medications. So this was highlighted through our structure survey that so if your hypertension was controlled, your average follow-up time is about 3 months. If uncontrolled, it's about 1 month. Refills are usually offered by non-pharmacists among bigger and larger hospitals. And as you can see, they only offer refills once their hypertension is under control. And the average duration you can get refills on is usually about 2 to 3 months. So here is the actual clinical audit of the newly diagnosed patients. So of 1,406 patients, we found that 55% did not start medication correctly. Now, what we mean by did not start medication correctly is most of our patients were not, their cardiovascular risks were not assessed. So once 50% did not get their cardiovascular risk assessed, then those at high risk who were supposed to be on duotherapy did not start on duotherapy. And some who were maybe at low risk were started duotherapy. So we found a 50-50 mix. So those people who were supposed to be on monotherapy, 50% were on duotherapy. Those who were supposed to be on duotherapy, 50% started on monotherapy. And then we also found that about a little bit over of a quarter did not receive any medication adjustment despite their hypertension being uncontrolled. So as you can see from the slides here, we also surveyed what medication we used as a first-line medication. So commonly used are CCBs. Amlopine is commonly used here in Thailand, followed by ACI, anafril. ARB is very little used, as well as diuretic. So as you can see, during the first year of treatment, more than almost 60% of patients were on only monotherapy. The rest were on multiple drugs, but only 1 person out of 1,000 received fixed dose combination pills. Next slide, please. And now we look at the control rate. So we have 2 measures of control rate. If you want to look at 6 months control rate, we're at about 53%. This number is probably underestimated a little bit because we have about 10% that did not come to the office visit during the specified time period. So if you look at the last visit, the control rate jumps up to 64, and the duration under treatment for the last visit is a little bit over a year. So we can say after a year of treatment, the control rate for hypertensive patients in Thailand is about 64%. And there's some varying degrees of variation among the 4 provinces that we sampled from 54 to 68. It's also good to know that we only lost 10% of our patients, so 90% of our patients were with us at least for a year. So next slide, please. So what did we find from our overall survey is we found that, I think as many people know, we have good infrastructure, good facilities, we have good diagnostics. We have regular supplies. We've never had medication shortage. We did some patient survey. We found that patients were very satisfied with our survey. But to highlight here, we found that despite the excellent infrastructure and the supply, blood pressure control is only around 65%. And from our patient survey, we also found that non-adherence is common to the guideline. So as previously said, patients were not on duotherapy when indicated. And we found out basically it's because of there was no cardiovascular risk assessment. And also in the hypertension guideline itself, it did not specify when to start duotherapy, when to increase the dose. So there was not a specific protocol within the Thai guideline of how we need to adapt our medication. So next slide, please. So the overall recommendations from our survey is, and this was also reflected by our qualitative interviews of physicians, that although the national guideline exists, there needs to be a simplified version, a protocol, as mentioned here, of what medication to start, when to adapt, when to add a second medication, because we see varying patterns going on here in Thailand at different levels. It's also because we know that 50% of our patients, according to the Thai guideline, should be started on duotherapy. So, and as you see from our slide, nobody is getting fixed combination therapy. So it may be useful to have combined pills within the Thai settings, because to start from one medication to 2 medications, sometimes it's harder to convince the patient to start taking 2 medications at once. So with that, I hope that is the conclusion of my slide. So thank you very much.
Thank you very much. What we'd like to do is we'll continue with the rest of the presentations, and then we'll take some discussion and questions and answers when we're done with all the 3 panelists. So now I'd like to introduce Dr. Prabdeep Kaur.
Thank you, Mark. A very good afternoon to all. I'm Prabdeep Kaur from India. I work in the, is it audible? Is it audible now? Good. Hi, I'm Prabdeep Kaur from India. I'm a physician and an epidemiologist working in the area of non-communicable diseases. I'll be sharing with you the initial experience from the hypertension work that we are doing. To begin with, we have a very large burden of hypertension. Yeah, very close. Okay. So India has a very high burden of hypertension. There are nearly 200 million patients in the country, but unfortunately, only 1 in 10 have their blood pressure adequately controlled. And the challenge is at various levels. And we also have a very mixed health system where 3/4 of the patients seek care in the private sector. Although there are variations across provinces where in certain provinces, the public sector is utilized more, but in majority of the provinces, private sector is utilized by majority of the patients. Next slide. So I will not be repeating this slide, but just to give you the background that the India Hypertension Control Initiative is built on these 5 strategies, which were outlined by Dr. Mark earlier. And we have adapted in each of these areas, we have adapted the strategy to the local context in consultation with various stakeholders. So we have protocols adapted in Indian context, and also the other various aspects which I'll be mentioning in the subsequent slide. Next slide. So India Hypertension Control Initiative, it's a multi-partner initiative. It's currently operational in 5 states or provinces and covering approximately 25 districts. And so far, 100,000 plus patients have been registered. It was launched in November 2017 at the national level. And the objective is to strengthen the hypertension treatment under the national NCD program. So Government of India already has a program which has emphasis on screening for hypertension and diabetes, both at the population level as well as opportunistic screening in the health facilities. And what we aim to achieve is to strengthen the management of patients who have been identified through the screening program, and also strengthen the follow-up and see to it that a large proportion achieve control over a period of time. So the partners include World Health Organization, Indian Council of Medical Research, Ministry of Health, various provincial governments, vital strategies, and we have a sort of a national level steering committee which oversees the overall policy level framework for the project. And then we work closely in each province with the provincial stakeholders to develop program and strategies at the field level. Next. So just to summarize, what are the key activities? Since the program has been operational for almost a year now, but it was started in a phased manner. And although we began in one of the province in January of 2018, two over the period of next 6 months, and the last two provinces just began in the November of last year. So I think one of the first important activity that we undertook, as Mark mentioned, was we worked with the provincial governments and we adapted, we actually shared the protocols from WHO HEARTS, and in consultation with the local stakeholders, the protocols were adapted to the local settings. We work closely with the provincial governments to ensure that the drugs are available according to the protocol. So, and we identified several challenges in procurement as well as supply of drugs. I mean, there were challenges in terms of budgeting, procurement at the provincial level, as well as rational distribution at the facility level. The third important area was ensuring the availability of good BP monitors, because without that, the measurement of blood pressure cannot be done, or we cannot ensure good quality measurements as patient comes for multiple visits. So once these things were in place, the next thing was to ensure capacity building of all cadres. So starting from doctors, nurses, health worker, in these 25 districts, all of them were trained. We also worked closely and we ensured that there was a dedicated staff nurse either under the NCD program or a designated staff nurse who might be doing other activities as well, but she's available to take care of the registration and follow-up of hypertension patients during the OP hours. We are in the process of operationalizing community level approaches, wherein it's possible that over a period of time, if the patient doesn't return, we can contact the patient, and also working closely with the governments to develop mechanisms for tracking the dropouts. And lastly, and the most important, is to have simple, easy to understand monitoring formats. So we implemented a simple patient card and a register, which is a line list of all the patients with high blood pressure maintained at the facility level, and ensuring that during every visit, the patient blood pressure is documented in the card. And lastly, the program has a dedicated manpower to ensure supervision and reviews. So there are medical officers, which are called cardiovascular health officers, who work at the provincial and the district level to monitor the program and to do supportive supervision and do hand-holding as and when required at the facility level. In addition, there are treatment supervisors who use a standard supervision checklist and routinely conduct visits across all the health facilities. Next. So before I end, just want to show you a sample protocol, which is being used in one of the provinces. As you can see here, the idea was to have only 3 drugs and very clear dosage. So it's much easier to conduct the training, and it's easier for the health provider to also use these kind of protocols. Thank you very much.
Thanks, Dr. Kaur. I'd like to introduce Dr. Pathni to tell us about her work in India.
Thank you, Mark. I'm Dr. Anupam Patni, and I am working with Resolve to Save Lives initiative in India. Next slide. So I'll be talking about what we have been doing in hypertension control in the private sector, what has been our role in it. So in the beginning, just to give you an overview, can I have the next slide? So India, we have a population of 1.3 billion, out of which almost 70% or more than 900 million stay in rural areas. The healthcare landscape is characterized by low numbers of qualified health workers, a large urban-rural differences in distribution of qualified health workers, with most of them concentrated in urban areas, though the population is less than 30% in urban areas, and large presence of unqualified health workers, especially in rural areas. A study showed that less than 1 in 5 of the doctors in rural areas actually had a medical qualification. Next slide. As Dr. Prabdeep has already mentioned, more than 70% of outpatient visits take place in private sector, and this is across urban and rural areas. But the private sector is very heterogeneous, very diverse. It consists of practitioners of modern medicine, which are known as allopathic doctors, practitioners of Indian systems of medicine, also known as Ayush, that incorporates Ayurveda, Unani, homeopathy, yoga, naturopathy, etc. And also we have informal providers that they come from various backgrounds. They could be faith healers, quacks, unregistered chemists, indigenous healers. So to just give a sense that the private sector is so diverse, and plus the type of facilities can vary from single provider standalone clinics to multi-specialty hospitals and private medical colleges. So to involve the private sector, we need different strategies. Next slide. But why do we need to involve the private sector? As Dr. Prabdeep has already pointed out, that there are an estimated 200 million hypertensive patients in India. Only 1 in 4 of them are aware of the hypertensive status, and only 1 in 10 are under control. The Government of India target is aligned with the global NCD target of 25% relative reduction in prevalence of raised blood pressure by 2025. To achieve this target, an additional 45 million patients with uncontrolled blood pressure would need to achieve BP control by 2025. We cannot do this in public sector alone. So we have to go to the private sector. Next slide. But there are several challenges. We have different health programs have tried to involve the private sector, TB, HIV over the last few years. The major challenges are fragmentation of providers and facilities. How do we engage informal providers? Considering the fact that they cater to a large proportion of rural population, there are no clear pathways. How do we involve the Indian systems of medicine? In many of the states in India, under law, they're not allowed to prescribe allopathic medicines, even though they do it. But we cannot engage with them formally because under law, they're not allowed to do it. There's no standardization of quality or costs, no systems of accountability or oversight. There is lack of mandatory continuing professional development and recertification of doctors. In addition, we do not know what are the control rates in private sector regarding hypertension, what are the regimens largely which are used, how to incentivize effective treatment, what are the current models, what are economics of private providers, which especially when related to hypertension management. So we need some answers. So what is Resolve doing in India? Next slide. So till date, the key strategies that Resolve is pursuing is essentially learning from different programs. We are implementing pilots, focusing on scalable impact, and hope to learn and optimize along the way and show these as demonstration projects. So one initiative that we have started with PATH in urban slums of Mumbai, and we are working with their network of providers who also worked in the TB program. So we have a network of 80 providers who are being encouraged to use the state government or the provincial government's recommended treatment protocol. And we are assisting them in counseling and follow-up of the patients. And over the next 2 years, we hope that 17,000 patients with blood pressure would be under treatment through this project. Another initiative, which is in its early stage, is leveraging telemedicine and technology-enabled non-physician health workers in Bihar with intermittent physician support, which could be face-to-face initially, and over a period of time graduate to telemedicine, more and more of telemedicine support. The Resolve technology team has developed a digital platform that is also known as a simple app, which can be used in any Android device, whether it's a desktop or a handheld smartphone. And these can be used for monitoring and follow-up of the patients. In addition, follow-up of the patients, we are exploring various ideas like sending texts, interactive voice responses, and having a call center to send patient reminders. In order to ensure uninterrupted supply of drugs, Resolve is in talks with leading pharmaceutical agencies to set up a virtual drug bank using vendor-managed inventory to have a quick turnaround time for supply of drugs to our private sector initiatives, and hopefully over a period of time, if we can show that they are successful, leverage it for public sector as well. For advocacy for evidence-based treatment protocols, we are setting up a hypertension control champions network who will advocate for protocol-based treatment as well as mentor young professionals in their network. In addition, we are sending out mailers to private sector, sending them the mailers regarding which is a recommended treatment protocol in their state, and following up with a few sample of these providers using public health detailing, which is a pharmaceutical marketing strategy where our consultant will visit them on intermittent intervals and advocate for evidence-based treatment and follow-up of the patients. Besides this, we are also trying to generate evidence in the form of, we're working with different partners to see based on what is the sales of drugs over the last 3 years, to generate evidence on which brands are most prescribed, whether it's generic, fixed dose combinations, especially in the private sector, and also working with another partner to generate evidence on which model can be useful, what are the incentives which drive private practice, and how can we leverage hypertension and which incentive will work. So these are a few of the strategies that Resolve is doing in India. There are no clear answers, but we hope that over a period of time, we have at least a few of them. Thank you very much.
Thank you, Anyapam, and the rest of our panelists for giving us a nice overview of some of the plans and some of the early results from Thailand and India. And I wanted to recognize a member from the World Heart Federation and the InterAmerican Heart Foundation. I knew it was both global and also American. And I know I was hoping that you could make a few comments, perhaps give us a little global perspective about how this might fit with the roadmap, or something else you'd like to speak to the group about concerning the World Heart Federation.
Yes, thank you, Mark. I am Beatrice Champagne, and I've been well introduced by Mark. I work now for the World Heart Federation as chair of the Advocacy Committee. And I wanted to mention about a tool that might be useful because it tracks so well with the Resolve program. The World Heart Federation has put together road maps. Many of you may be familiar with some of these roadmaps in the area of cardiovascular disease. These are all frameworks that help us identify the best interventions, the obstacles that we might run into, the potential solutions to those obstacles, and also adapt solutions to local needs. I found that in looking at the Resolve 5 key elements and also at the roadmap from the World Heart Federation, they are very comparable and very similar. And they deal with simple evidence-based protocols, access to affordable medications, task sharing or community-based treatment, patient-centered services such as care at local health centers, and also information systems, particularly monitoring. There was a very good experience in Kenya associated with these roadmaps, and you can find them in the World Heart Federation website. I think that it would be a good addition, particularly the look at the obstacles and how best to resolve those obstacles. I think that this is something that might be useful to this audience. Thank you.
Thanks, Beatrice. So now what I'd like to do is to open up now we have about half an hour, or maybe a little less, so we can do some concluding remarks. And I have some prepared questions, but the prepared questions those are too easy because the panelists have rehearsed the answers. So I have a set of prepared questions. I think I'm going to ask one, and I'm going to ask a hard one. And then what I'd like people in the audience to think about, think about how you can tap the brains of these experienced implementors, because after all, it's all about implementation. So what I wanted to ask was the question number 4, which is, we've heard about barriers to care, different barriers in different countries. But if you had to select the one most important barrier to see for hypertension control, and you had to tell people in the audience who are about to implement something, hey, what's the biggest barrier for patients accessing hypertension treatment? And that would either be, I don't know, meds or devices or access clinics. What would it be? And we'll go in order from right to left.
Thank you. So I think in order to achieve hypertension control, at least from our data, it suggests that at least first you need to get the right people into treatment. What's happening from our survey is, of the 1,400 new cases, only 10% came from screening. What is that saying? That's saying those people who are already sick or in the system are the ones getting diagnosed. And our screening program, although despite excellent coverage of screening, they're not getting diagnosed for some reason. So there's a gap. And I think from other studies in Thailand, we know that this gap is, men are less likely to come. They're screened as positive with high blood pressure. They're less likely to come to get diagnosed. People at a working age, they're less likely to come and get diagnosed. So I think getting the diagnosis, getting people into treatment right is a crucial factor. But in terms of getting blood pressure under control, I think, at least from the survey that we did, it highlights the need for a simplified protocol and algorithm to actually help physicians do this, because in further analysis of our study, we found that it didn't matter whether the physicians adjusted the medication or they didn't adjust the medication, the odds of hypertension control did not differ. So what's that saying basically, from at least looking at the actual data and what the records are saying, is because there's such variations in how doctors are adapting the medication, adjusting the medication, it didn't seem to make a whole lot of difference in terms of blood pressure control. So that would be my initial response. Thank you.
Wow, great. And for those of you listening, that was actually 2 barriers rolled into one, but that's great. We'll accept that. So we'll give everybody else their 2 barriers, okay?
Thank you, Mark. So I will not repeat what he just said. I think the low awareness and detection is a challenge in India as well. But I think for the patients who are already detected, I would think the biggest barrier is availability of drugs. And not just availability of adequate quantity of drugs, because quite often the drugs are prescribed for 7 days or 10 days, and it's just like how the infectious disease treatment used to be given. So we need to ensure that the drugs are dispensed. In India, we are trying for 30 days, but hopefully over a period of time, at least for 3 months. And what's very ironic in India is that the drugs are very cheap. So it costs less than $2 a year to actually treat one patient with hypertension. But unfortunately, we don't have adequate numbers available. If I have to say that among patients who visit facility, but we do have certain provinces where drugs are not a challenge. And in those settings, getting the providers to adhere to protocols is, I think, another big challenge, which is already highlighted by my other panelists as well. Thank you.
I think, besides all the challenges which have already been mentioned, I think therapeutic inertia is a very big challenge. And we have seen that despite the protocols, despite having simple protocols, despite the medicines, the doctors just do not step up the medications. And this we see it on every visit. And plus beyond that, I think, looking at private sector, I would say that the patient's involvement in their own care, the lack of proper counseling, and be to impress upon the point that this is lifelong treatment. Many of the patients take it for a week, a month, 2 months, and they stop because it is asymptomatic. So patient has to be involved, the whole family has to be involved. So I think that beyond the other challenges that I mentioned, this point is extremely important. Thank you.
Thank you. I would just like to just comment that what you're describing is adherence. And we think of adherence as being something that the patients do with their pills or their activity, but what you three of you have all kind of danced around is a concept of adherence, of provider adherence to appropriate blood pressure titration, initiation, or the gap between screening and diagnosis. So I think it's very easy to blame the patients. That's what I do usually. No, I'm just kidding. But I think it's very easy to blame the patient. It's very convenient. But what you're really describing is that we need to work on how we ourselves adhere to the policies and the practices that we believe are best when we look to the resources we have and the evidence. And so maybe when we think about adherence, we should be thinking about, it goes both ways. So thank you for pointing out those barriers, which have many things in common, yet we're slightly different. So I'd like to open up for questions on the floor here. I do have my prepared questions, but I'd like to hear from our live studio audience. So why don't you raise your hand and I'll bring the microphone. Yes, Dr. Abhishek. Why don't you go ahead and state who you are and where you're from? I know it, but the rest of our audience may not.
Thank you, Dr. Mark. So I'm Dr. Abhishek from WHO India, and I'm consultant from Hypertension Management Initiative Program in India. So I have just a question from Dr. Chaisiri. Sorry if I am incorrect. So there I mentioned that there are 53% control rate in your study and 29% of uncontrolled. So did any analysis that, like we are talking about adherence of the drugs, so these 50% patients adhere to the drug what were prescribed, and this 30% did it adhere to drug? Do you have some analysis of that? It will be better to understand. Thank you so much. And one last question, if the added question is 6% was default. So can you just elaborate that what are the mechanisms in the Thailand has been done to control the loss to follow up? So there is very less loss to follow up, if you have analyzed in this study. Thank you so much.
Thank you, Dr. Abhishek.
So, like I said, because adherence to the guideline is whether you adjusted medication or not how you adjusted medication. So the numbers that the gentleman was asking was, did it make a difference whether they adhere or they did not adhere? And from our data set, I am going to say no, it did not. We found that people who did not get their dose adjusted, people who got their dose wrongly adjusted, people who got their dose adjusted because they were uncontrolled, the probability of getting hypertension under control at 1 year is actually pretty similar. Now, of course, I've gave a short discussion of why I think that's happening, but I think it has to be a little bit further study. For the low loss to follow-up rate, I think my colleague from the ministry would be a better person to answer why we have such a low follow-up rate. So if I may refer to my colleague, is that possible? Thank you, Dr. Spatra.
Yeah. Okay. So the system, we can say that we have already like that registration. For those who have already case finding, then they got registered. They have the system to follow. If they have the problem that they can not adherence, not come to the clinic, usually they will maybe have a phone call or even ask the health volunteer to ask whether what is the problem. That is a system that we have already worked. So it means that the system for the treatment is not only based on the doctor, but we have the team of the primary care team. Because we can say that the infrastructure of a Thai healthcare system is quite good, available in everywhere, in every district. So the people can access quite very well and very easily. So the problem or the pocket is just those who maybe is a migration. Right now, then when the people have a migrate, since that we have on the primary care that area based. So if they migrate, sometimes they did not there to maybe to got some drug in some other service, even they can do, right? That is just some problem with that.
Okay. Thank you very much. Okay, so why don't we take the question in the back here? I'll run with the microphone and go ahead and introduce yourself. Yes, very back.
Good afternoon. I'm Leanne Riley from the World Health Organization. I'm the coordinator for NCD surveillance. I was very interested to hear a little bit more from Dr. Pradeep about the supportive supervision that you mentioned, because that seems to be one of the techniques maybe to address this problem with provider adherence. And so I'd like to just hear a little bit about what you felt was good practice there.
Thank you. With one microphone, I'm getting a lot of exercise here. So thank you.
We're practicing what we preach. Yeah, so the supportive supervision is one of the core areas of our project. So the project has sort of designated manpower to do this activity. So we have a doctor who's called Cardiovascular Health Officer, who is placed at the district level. And we have what you call as a treatment supervisor, who is basically a sort of a technical person who is trained to do supervision. So they make a sort of a monthly calendar, and they try to cover as many facilities as possible during that period. While they visit the facility, they use a standard supervision checklist, which essentially covers all these 5 core areas. So they actually go and they look at whether the opportunistic screening is going on, whether the cards are being used, whether the registration is done, if the BP measurements are done as per the guidelines. They review a sample of patient cards, and they also compute what's the blood pressure control in the group, I mean in the card which they reviewed on that day, and they look at the protocol compliance as well. So after doing, and they also visit the pharmacy and look at the availability of drugs, and they try to compile the data for the whole district and share with the district officials. So if there is a shortage, they can do a planning for coming months. So what comes out of it is kind of a summary at the end of every month. In addition to that, we have what is called as a quarterly indicator, which is as per the WHO HEARTS initiative, which is done for a cohort of patients who have been on treatment at least for 6 months. So after 6 months, their blood pressure control data is collected, compiled, and analyzed, and shared with the various officials. So this provides an opportunity to reflect on what are the challenges on the ground. So it could be that in one place, drug is a problem, but in another place, drugs are there, but the compliance to protocol is poor. In another place, it could be that default rates are high. So it really gives an opportunity both for the district officials as well as for all the other stakeholders to understand ground level challenges. Thank you.
Thanks, Prabdeep. I'll go to the back here, and then Sohel, I guess you next. Oh, thank you.
So I would like to congratulate 3 speakers because I am from India. I am working in drugs control department at national level. I would like to congratulate both Anupama Madam and Kaur Madam. Madam, here you have described all important things because availability of medical products to take care of hypertension patients. Is there any challenge? Because it was launched in 2017. We are in the process, Ministry of Health and WHO and ICMR. With synergy, you are all working, taking care of all important patients as per your protocol. But what are the drugs? So that at least I can convey to a department or manufacturer for access and availability, and affordability is our main objective with respect to health ministry policies concerned to take poor needy people across the country. This is number 1. Number 2, recommendation. One of the International Society of Hypertension, you have given one of the last slide, recommending the fixed dose combination of different hypertensive drugs. Because in India, as per the Supreme Court advice and directives, we have banned almost 394 products. So because it varies from the country to country, but if you can see what are the critical process variables involved with respect to the manufacturing process involved for the development of different dosage forms for the treatment of hypertension, primary hypertension or secondary hypertension. But do you have any comment on the recommendation on fixed dose combination FDC products? So this is only for clarification as a regulator. For curiosity, I'm asking. Thank you.
Thank you very much. And before we let our Indian counterparts respond to the fixed dose combination question, I will point out that we've heard and seen a lot of interest in fixed dose combinations, and we were frankly surprised that they were not embraced. And one of the reasons, we believe, is the fact that they are not on the World Health Organization essential medication list. So Resolve to Save Lives, with several other consultants and co-sponsors, have submitted a petition for 4 different types of, which cover most classes of fixed dose combinations, single pill combinations, basically a 2-in-1 pill, to be added to the World Health Organization essential medications list, which is probably going to be adjudicated sometime in a few months in April. So we are working on that behind the scenes, right, to help that. But I'd be also interested to hear from the 3 of you about your response to that in the previous question.
I'll first respond to the first part on the challenges. So Government of India has a program wherein at the national level every year a designated budget is allocated to the states or the provinces, because health is a state subject. So about 70% comes from the central level and the remaining is allocated by the provinces. However, the challenge is very complex and it's at various levels. Since NCDs are relatively new, so we don't have adequate data in the health system to do proper forecasting. So quite often the budget which is provided to the states is based on the requirement which they calculated, which is often wrong. Because it's based on some guess, based on how many patients came in the previous year. But since there are no robust databases, this data is often not accurate. For example, we looked at one of the provinces and we found that their next year estimates were only 1/4 of what actually will be required if they decide to provide 30-day drug for all the patients who are registered. So that's one challenge. The other challenge is the procurement mechanisms which are put in place, which are very diverse in India. We have some of the best models of procurement in certain provinces, whereas in other provinces, the mechanisms are not so robust. The next level of challenges, even if drugs are available, ensuring the rational distribution and at the facility level, ability of the pharmacist and doctors to place correct demand. So quite often due to lack of data, they don't know how much they require for the next quarter or for the next 6 months, and that leads to stock out. So I guess we need to work at the various levels, and we are doing that. We need to build capacity of the facility level pharmacists, doctors to do better forecasting, capacity of state level officials, as well as the drug procurement departments to do good budgeting, planning, and forecasting. And of course, coordinate at the national level to ensure that the adequate budgets are allocated. Thank you. The FDC question, I'll pass it. Sure. You want me to answer?
And would any of the panelists like to make a comment also? Yes, and then we'll have Dr. Frieden make a comment.
Thank you. So adding on to what Dr. Prabdeep just mentioned, I think when we had these protocols, 5 states, we've started this program in 5 states. Each state has basically selected these 3 drugs, amlodipine as a CCB, telmisartan as the ARB, and chlorthalidone as the diuretic. But the National Essential List of Medicines does not include chlorthalidone. So it's been a challenge to even procure chlorthalidone. So most of the states have started using hydrochlorothiazide instead. Most of the state EDLs did not even have telmisartan, though their own committee had decided on these 3 drugs, but to get it into the state EDL, into the procurement mechanism itself was a challenge. That itself delayed it. And now slowly some of the states have included telmisartan in the EDL. So in the interim, they continued using losartan. Another challenge is even if the drugs were there, there were lack of rate contracts. So to getting rate contracts in place also took a lot of time. Some states could not do it, and so in fact one of the provinces used another province's rate contract to procure drugs. So these were interim measures. And like Dr. Prabdeep has mentioned, poor forecasting, and because of stockouts, the consumption would be less in most of the districts. But what the pharmacists normally do when they place demands, they usually normally do it on consumption method, while we want them to do it on morbidity method. So there has to be a balance between the two. So if they forecast only on a consumption method, they will put the demand that they will put to the state will be very less. So there were a lot of challenges, not one single answer, but we need to address all these, to ensure uninterrupted supply of drugs. And most of our consultants in the States are dealing with these issues on a day-to-day basis. Thank you.
Thank you, Dr. Frieden.
So great questions. And just to comment about the drugs, first, as Dr. Patni says, quite striking that essentially every place selected the three drugs. They're all generic, low cost, safe, effective, once daily. And interestingly, all over the world, we heard the same thing very strongly. We want to minimize adverse events. So any drug that would increase that would be less favored. And we want to minimize the need for chemical monitoring of potassium. But for the fixed drug combinations, what we're seeing is the private market, they're dominant. So if you go to a private doctor in most parts of the world, that's what you'll get. And you might get a rational FTC or you might get an irrational FTC. But what we've tried to say very clearly, and our application is available on the web, is that there are very rational FTCs for hypertension. Now, this issue gets fairly complicated as you discuss more than two drugs. But we've started as a first step with 2-drug FTCs. And there are several different rational categories of combination for 2-drug FTCs. We're optimistic that those will be approved by WHO in April and finalized by World Health Assembly in May. What we found as we did consensus conferences was that the practitioners wanted to choose the FTC, but because it wasn't on the country's EML, because it wasn't on the WHO EML, they didn't and they couldn't. Now, there are a couple of issues to be clear about with FTCs. One, as I frankly learned as our consultants reviewed all of the data on FTCs, not only do they simplify logistics, make it less likely that or impossible that you run out of one without having the other, and they don't have a higher rate of adverse events, but strikingly, they're associated with about a 20% increase in control rates with the same medications. So they have a really important value in addition to the logistics value. The concern people sometimes has is, well, what about the cost? What we hope is if we can see 2-drug combinations with 2 of the 3 drugs that all of the countries have selected, we may be able to see a real reduction in cost. As we increase the value and standardize, we may be able to see a real reduction in cost, such that, in fact, in other diseases, fixed drug combinations are less expensive than the individual drugs because actually the pill production costs are lower and the packaging costs are lower. So we hope in time what we'll see is not only a drug that's better for patients, but also less expensive.
Okay, I want to make sure I get to the rest of the question, as long as it's brief, because I want to make sure I get to the rest of the question.
So excellent comment, but total WHO is developing a guidance document on FDCs, but because practitioners, physicians, doctors, they will always encourage with respect to FDCs for their business purpose. But until and unless we have the scientific data to safeguard our public, we have to be very, very critical. Once we develop and give the permission for the FDC, after 2 years, we'll get the serious adverse event, then we have to go for the ban. So recently, we have received one combination requesting to have amlodipine, aspirin, hydrochlorothiazide, and telmisartan. Very interesting. Sorry.
Well, thank you. I would just point out that, so there are some challenges, but I think you don't need to look very far. Then there's lots of evidence that FTCs are safe and effective. And I just mentioned what Dr. Frieden mentions is that there also can be reduced costs in terms of pharmacy dispensing costs and packaging costs. So when you add up all the costs, they actually might be significantly lower than two pills from 2 different bottles from 2 trips to the pharmacy for the pharmacy's time. I want to ask Dr. Sohel for a quick question, so I have a few minutes to wrap up. Okay.
Okay, I'm Dr. Sohel Chaudhary. I'm from Bangladesh and working for National Heart Foundation Hospital. And recently we have started a project with government to strengthen primary health care for hypertension service delivery with the help of Resolve to Save Life. And I have a lot of questions to these experts because we are at the initial stage of set of our program, but I will confine to only to Dr. Chesri about I understand that in Thailand you are using risk-based treatment assessment and the treatment. So in your clinical audit, what is the actually adherence to this risk-based assessment by physicians? I mean, whether they are approving this method or they jump to their treatment guideline. That is one thing. And another question to my Indian colleagues there. And this is also about treatment protocol. We know we have a standard treatment protocol, but what about the private sector? I mean, what is the pressure from private sector on government, and the public sector about this protocol? Because there are new guidelines coming out from different countries, and our cardiologists and specialists are saying that the consensus protocol that we have actually not reflecting the current recommendations. So how you tackle all these issues? Because we are facing the same problem here. Yeah.
Great. So Dr. Chastri, we'll let you answer that first question briefly, and then we'll let one of our two colleagues from India answer the second question briefly.
So in our survey, 50%, but there's variations. Some state almost zero, some province almost 70, 80%. That's depending on whether they have the program on the computer, whether that's readily recorded in the patient file. I would just add a little bit more though, that in further analysis, it did not seem to make a difference whether the physicians did or did not do a risk-based assessment. And let me explain it just a little bit. I think it's because we are seeing our patients very early, very quickly after initiation of treatment. So we look at our data, we know they're followed up very quickly. 1 week, 2 weeks, 3 weeks. On average, our patients are followed up 8 to 10 times in the first year. So we know they're seen quite quickly, and physicians can tell when hypertension is uncontrolled. And as our data suggests, they do tend to adhere to the guideline in terms of adapting the medication. So I think that's why, although they're not doing it, it did not seem to make a difference on the outcome. And my initial response to that is probably because we're seeing them quite often. There's time to adjust. And that goes back to the same point that if we adjust well, potentially we can make a difference. Thank you.
The second part of the question regarding, is it about acceptance? Is that your concern? So very interestingly, we did not have much of a challenge around acceptance. And many of our the meetings, consensus meeting did include experts from private sector as well, who are kind of recognized at the national level or respected by the peers. And they all felt that this 3 drugs were acceptable to the private sector as well. We have also had smaller sort of group meetings with the private providers, and many of them have said that if the government is willing to collaborate, we are happy to prescribe these medications. So, of course, there is a group of providers who are not in the favor of starting with amlodipine, who felt that ARBs should be the first line of choice because that's more preferred in the private sector. And there are other providers who would rather go for fixed dose combinations. So that's quite often prescribed in the private sector as well. But in general, there has been no major, I would say, opposition or negative feedback from the private sector on these protocols.
Well, thank you very much. I want to thank all the people in the audience. Oh, I'm sorry, we don't have time for any more questions. I want to thank all the people in the audience for asking the questions, and especially the 3 panelists. And just to summarize what we went over today, we talked about adherence being maybe adherence to maybe the medical system's adherence to a protocol. We talked about how medication availability was very important, but as our colleague from Thailand mentioned, even the availability of medications alone is not sufficient to have maximal hypertension control. We talked about the difference between screening and making it to follow up to get your diagnosis after screening. Talked about the advantages of having a simple protocol. And I just find it fascinating that in India, they're starting with a simple protocol and moving forward. And in Thailand, they've already moved forward, and now they're going to go rethink having a simple protocol. But either way, it seems like having a simple protocol catches up to you at some point in time. Supportive supervision and how important that is to check the activities and to counsel the people practicing in the system. Forecasting, how difficult that is and how the old way of forecasting might not really work in the new era of hypertension treatment. We talked about single pill combinations and the paradox that they're recommended by many in private practice. They seem to be given liberally, but in large systems, there tends to be a reluctance or an inability to move forward. And we're hoping to chip away at that little by little. We heard many other things as well. So with that, I think it would be time, Funka, to have our 5-minute, our Okay. Oh, there you go on the slide for me. There you go. Thank you. A 10-minute break. So thank you very, very much. And we'll look forward to discussions about salt and trans fat coming up next. Thank you.
impaired kidney function, the low sodium salts have a double benefit of increasing potassium and reducing sodium. Next slide. When it's a question of packaged food, then industry reformulation is extremely important. The United Kingdom was perhaps the first in the world to do this, and they showed quite substantial reductions through setting voluntary or mandatory targets. There also are examples from South Africa and elsewhere of countries making progress through working with the food industry. There's a clear educational component of nutritional labeling, such as front of pack warnings, and we've been very impressed with initial information from Chile, which has a very effective nutritional intervention program, whereby they require a warning on high sodium foods, as well as restriction on advertising those foods and restriction on sales to government venues such as schools. Another approach which we understand is being considered here in Thailand is taxation of high sodium foods. We think this is very promising. It's very exciting. We hope something like this will be possible as soon as feasible. We know with certainty that for alcohol, for tobacco, and for sugar-sweetened beverages, tax is king. Tax is the single most important intervention. It doesn't mean we also don't do other interventions, but among all of the interventions, it is the first among equals. It has the biggest impact. And there are, of course, a lot of complexities in how products could be taxed. So the details of doing that will be very important. We know that, for example, there were traditional taxes on sugar-sweetened beverages which were too small to have an impact. But when we began to push for a penny an ounce tax, that began to show very substantial decreases in consumption. So the sodium tax can be used as a market-shaping mechanism. Finally, the target of restaurants and canteens, I would say in all of the hard areas within sodium, this is the hardest. We don't see a lot of success stories around the world engaging with restaurants and food vendors to reduce salt in foods. I've had delicious low sodium food in Shandong province, so maybe we'll hear some of that from Shandong, because they did work with restaurants there, but this is a sector that's difficult to work with. There also is the possibility that government and private sector procurement policies can limit salt, saturated fat, added sugar for foods purchased and served. And one of the things at Links that we're just recently, and at Resolve to Save Lives, we're recently considering is, can we work with any governments or cities, national or city governments, to come up with a very simple concept. If we are the government and we're buying food with public dollars, and we have government standards for healthy food, why should we allow anything other than healthy food to be procured or served on government property? Sounds like a simple approach, but it requires a lot of work to get it implemented, and we're very interested in working with a few places that might be interested in implementing this policy. Next slide, please. The objectives of this session are to provide tools and proven strategies to improve cardiovascular health, to highlight successes and lessons learned from the field in these three areas, and to inspire action to address cardiovascular disease, the world's leading cause of death. Final slide. We have three panelists, and we're going to start with Dr. Sirasek, then Dr. Choyol Kim, and then Dr. Ma from China. Each of them have implemented programs that are very effective. They've been advocates and champions within their countries, and I think all of us can learn from them. Dr. Sirasek.
Okay. Thank you very much, Dr. Tom, and for inviting me to give a talk here. And I would like to talk about the overview of sodium reduction program in Thailand. Next, please. For our situation, Thais consume about double of the requirement of 4,300 milligrams of sodium daily. And the dietary source of sodium include 30% from home cooking and about 30% from street and restaurant food and 30% from packaged food. We mean packaged food that they can buy from the convenience store or supermarket. And instant noodle is quite popular among Thai people, and they consume about 8 million packages of instant noodles every day. And seasonal cube is also very popular, and which were added more than 90% of all cooking, whether in house cooking or in restaurant or street vendor. The burden of hypertension is about 13 million people affected by hypertension, and about 7.6 million of people have chronic kidney disease. And the cost of dialysis in Thailand is 800 million US dollar per year. And we analyzed our strategy about the cost effectiveness, and we found that the food reformulation strategy is the most cost effective to prevent NCDs. Next. This graph shows high and variable amount of sodium in packaged foods, and the y-axis list of the products that can be purchased from in the market, about 160 of instant food, and the x-axis is the sodium content of each package. And you can see that the sodium content varies between the lowest one is 1,000 milligram per 100 gram of package, and the highest one is about 4,000 milligram, and the mean of the products mean sodium of the product is about 2,541 milligram. And in our target, which we set up the voluntary target for sodium reduction in industrial food, is about 10% reduction every 2 years, and we plan to reach about 30% reduction within 2025. Next, please. The national response in 2011, we have the National Daily Sodium Survey by Food Recall, and we found that most Thai people consume about double of daily requirement. And in 2014, we established the Low Salt Network, which include Nephrology Society of Thailand, Academia, Ministry of Public Health, and Food Institute, and other consumer group. And a year later, we proposed the sodium reduction policy to the National Health Assembly, and finally we passed the resolution to endorse the national policy for sodium reduction. And in 2017, the National Sodium Reduction Strategy was endorsed by the Ministry of Public Health, and which include 5 strategies: SALS, S for surveillance, A for awareness, L for registration and environmental reform, T for technology and innovation, and the last one is S is stakeholder network. And 2 years, within these 2 years, we have ongoing high-level national multi-sectoral committee meetings chaired by the Minister of Public Health, and include both health sector and non-health sectors. And we also have intensive engagement with food industry to set up a voluntary target for sodium reduction in packaged food. We also have we're quite successful in the social media campaign. We have released both infographic viral clip, which attract more than 5 million views last year. And FDA also issued GDA labeling and healthier logo on front of pack on snack, processed food, and ready-to-eat meals. Next, please. Our key achievements: we have good partnership and network with Ministry of Health, FDA, Low Salt Network, Thai Health Promotion Foundation, WHO Thailand, Academia, Food Technology Institute, and Consumer Group. And we this year we set the voluntary target for 5% reduction in sodium in packaged food in this year. And we last 2 years we have set up the low sodium hospital models, and now we have more than 80 hospitals in the country that have low sodium menus served in cafeterias for the visitors and patients, and also for medical staff. And we also have the good and successful social media campaign. We have performed key research conducted in food database on street food, on convenience store and supermarket, and we are successful for reformulation in most popular Thai dishes. And we apply salt meters for food monitoring and educating the people in hospital and community health, community by health personnel. And so far we have distributed the salt meter more than 83 hospital and several community area. Next, please. So the major challenge. So the high political commitment sometimes not translated into urgent operation action, and funds allocated are far lower than the magnitude of the problems. Our government, FDA, are not tough enough, so we can set voluntary target. We have a limited staff at FDA and with competing priorities issues. And the industry sometimes interfere with policy making. So we have quite small network of sodium champion, and we need more monitoring and evaluation. The last one, please. Last slide. Last minute, right? The next step, this year we going to do survey for sodium consumption by 24-hour urine sodium measurement nationwide, about 2,500 sample size. And we thinking about the issue, the sodium tax on high salt, high snacks, or instant food or instant noodles. And we need more media advocacy. So we plan to train the journalists to more understanding about the issue of sodium tax, and also social media campaign. And if we are not successful for engagement with industry for the voluntary target, so we may need mandatory target for reformulation, and warning labels on the front of pack may be beneficial to motivate industry to reformulate their products. We will expand the network of low salt hospital and schools, network of sodium champions, and we're going to do research on cost effectiveness on strategies for sodium reduction. Okay, thank you.
Okay, Dr. Ma, you can see what.
Okay.
Thank you. Thank you for kind introduction, Mr. Chairman. I'm going to tell a little bit about the approaches we have taken to reduce population salt intake in Korea. Next. You can hear me? We have long known problem of high sodium intake without any appreciable government action for a long period. And as you can see in the figure, because we have a nationwide health and nutrition survey in place, which is called K-Enhance, and it is conducted every year, we were able to see that there was another 10% increase in sodium intake from 2007 to 2010. And during the same period, we have noticed another problem of childhood obesity increase, and we had several instances of food safety problems in meals served to children. The government, which prompted the government legislation of the Special Act on the Safety Management of Children's Dietary Life. And with that act, the government was able to support a huge R&D project called SafeNet for Children, which had 5 strategic goals. And one of them was food and nutrition safety, assurance of children's food. And the major task included reduction in sodium, trans fat, and added sugars. And to have the policies of more sustainability, the government used some building blocks, including theoretical ground by supporting R&D for status analysis about the sodium intake, and also clearing misconception or misbelief about the sodium insensitivity among Koreans. There was misbelief that Koreans are okay to take high sodium diet because we are resistant to sodium, something like that. So after a 2-year metabolic study, we were able to publish a paper saying that about 1/3 of the Korean population is actually sensitive to sodium. And then even in sodium resistant population, the morning blood pressure still goes up with high sodium diet. It was good enough to clear that misconception or misbelief. And to increase the awareness, government did continuous issue making and launched a national movement with civil society, academia, professionals, industry, and media. And to secure the budget for the policy action, the government took the cost-effective estimation in advance. And we found that the total benefit we could have could reach up to 35 trillion Korean won, corresponding to about 33 billion US dollars, if we were able to decrease the sodium intake down to 3,400 milligram by 2025. And based on that, the first comprehensive plan for population sodium intake reduction with a clear goal was announced by the government, with a clear goal of 20% decrease by year 2020, which corresponds to 3,900 milligram from 4,800 milligram. To implement the policy and monitor the impact, the government government relied on the cooperation with food manufacturers, restaurants, and meal services by the national movement I just mentioned. The headquarters of the national movement to reduce sodium intake gathered to reduce sodium intake, and it was an autonomous voluntary action hub with the consumer, academia, association, and food industry to lower sodium intake. Under the headquarters, we had 5 subcommittees, including Meal Service Committee, Restaurant Committee, Processed Food Committee, Consumer Committee, and Academia and PNR Committee. And the local government joined the central government with customized tailored program for their residents, such as designating healthier restaurants serving lower sodium menus. And then to monitor the sodium intake change in publicity, we used the K-enhance again, and we were able to see that 800 milligram decrease after 3 years. Then what happened? Yes, the goal we have set for 2020 was reached in 2014, much earlier than planned. And so with that, government did another policy impact analysis in terms of cost benefit analysis. What we found was there was the total benefit was up to 11 trillion Korean won, corresponding to 10 billion US dollars for a 3-year policy. And then what happened then for hypertension prevalence in terms of that, although we struggled with the clear increase in the hypertension prevalence from 2007 to 2010, we don't see any more such big increase in hypertension prevalence afterwards. So that's what we have so far. And with that, we have second plan for sodium reduction in place with a goal of 3,500 milligram. Thank you.
Thank you, Tom, for invitation to share our experience on salt reduction. For the SMASH project, next. So we initiated the SMASH project. It is Shandong Ministerial Health Action on Salt and Hypertension, initiated in 2011. And this is the most important and typical Chinese character government action. That is the ceremony is from top leader, and this minister of the Ministry of Health and the governor of the Shandong province. We almost take 1 year to start this project. So once get prepared, so that we get political commitment from the government, then we started. And we also have a very good slogan. That is inside the sodium is in the center, and this is 6, the number of 6 Chinese recommendation on 6 grams per day on salt intake. So next. And this is maybe the sources of sodium. 80% were from salt added during cooking, and also others. So that is different from Western countries. So most sodium comes from salt during cook at home. So that next. And our strategy first is social campaign, media campaign, and second is school intervention. But not only school, it is a link of school children and their family. So that is a link. Salt intake is not determined by the children, but by their parents, especially their mother. So then that is a collaborative action. And also we conduct intervention on healthcare intervention, focusing on hypertension patients. Next. And also we conduct intervention in restaurants. That is, we have to develop Shandong cuisine standard. Before don't have such standard for salt. Then we introduce salt into their cuisine standard. And also food industry intervention also involved in this campaign. So we can see many kind of competition in restaurant and also for women's and many kind of media campaign on newspapers were conducted. Next. So this is the most important of the SMASH project. We set up this mechanism, the working structure from the national level. That is National Health Commission, currently previous Ministry of Health, and the Shandong Provincial Government. Below is the project office, and we include Bureau of Publicity, Education, Women Federation, and also Cuisine Association, Food, FDA, and all Nutrition Food Center. So such sectors, we define their responsibility and their action. So that is a 5-year project. We have very good communication within this almost 15 sectors. So next. So that is change our salt, the sales of salt in Shandong province. So after 2013, it reduced. Next. And this potassium salt increased hugely. Next. And for continental salt and dietary total sodium intake, we can see 20% reduction. Next. And this is 24-hour urine sodium and potassium sodium, urine sodium reduced and urine potassium increased. Next. So that is the implication from the SMASH project is that first is it is a population behavior change need a social system, whole social system. First is the awareness campaign. That is we get public agreement on salt reduction, and also from the governor and also for different sectors. And also we set up very good supportive environment, not only for restaurant, but also food industry. And so it is a whole social action, government leading, social media, multi-sector collaboration, and also it is a continuous and a long-term sustainability. So 5 years time, we worked with other sectors, and so we see achievements on this. Thank you.
Thank you very much. For each of our three presenters, we heard a systematic approach from Thailand, identifying also leading causes or leading vectors, if you will, of sodium and progress against those. We heard from Korea a very systematic approach to working, achieving targets ahead of schedule and documenting the very substantial economic benefits from that. And from China, we heard the tremendous power of a provincial government, the governor taking this on and requiring all of the government to work on it and see a substantial reduction. So we see it's possible. I'd like to start with two questions to the panel, and then we'll open it up for questions from the floor. First, the issue of voluntary targets, particularly in Korea and Thailand. How effective have those been, and how can we work to get countries to, or I should say manufacturers, to accept voluntary targets? Because you could have a situation where one manufacturer says, hey, if I leave my stuff salty and everybody else makes theirs unsalty, mine may taste better to people. So you have a little bit of a tragedy of the commons. And I'm wondering, how do you get the companies to come in line with voluntary targets? So please.
In Thailand, we just start this in industry engagement last year, and so we work with Thai FDA. We need the authorities to invite the food industry to come to a joint meeting, and at the beginning they are quite reluctant to cooperate with us. So after we explained, and we got the WHO representative to help and support us, and also the Ministry of Health to support. So they finally agree about 5% reduction of the sodium in the food products in every items. They say that in every items, but they promise only in the first year. But for the second or third year, we have to wait and see whether they will still work with us or not. Otherwise, we will have to use another strategies. And also, if they reduce their sodium contents in the products into target levels and lower than our average, so perhaps we will assign, we'll give them the healthier choice logo, which is issued by the Institute of Nutrition, Mahidol University, and FDA. So we gave them the healthier choice.
Maybe food industry not we didn't put much effort on that. Just but we also communicate with food industry. We asked some industry take volunteer on salt reduction. One is very important industry, food industry in Shandong is roast chicken. When you came to Beijing, in Beijing we have roast duck. In Shandong we have roast chicken, and that city is in Dezhou, like Texas in America, and that is another Texas in Shandong province. That is where the industry, chicken industry in, and they take volunteer on salt reduction on their product. And even some of my colleagues complain that the chicken is not so tasty. So they take a volunteer. And another volunteer industry is soy sauce industry. That is located in Yantai city, coast city. And also we have other voluntary industries, not so many, but they take action on the government request that they should lead the healthy behavior, and they hope to make contribution. They also want to make their own efforts and contribution on the people's health. So that is voluntary. So, but for further promotion, it is hard. Only some voluntary industry that is in Shandong. Yeah.
It's obvious that the industry would not go with us easily, and the government, what the Korean government did was we used power of Mothers Association, civil society, to make issues, and I thought I was speaking very loud. Okay. Okay, the government used the power of Mothers Association, the civil society, to make continuous issues. And also, as I showed in the slide for the national movement, under the headquarters, there was a subcommittee meant for the food industry. So they were given a chance to talk and work with us. And also, government kept working, kept having dialogue with food industry to kind of to let them join us in stepwise decrease in the sodium content, even though they didn't like it so much, because the main focus was given to kimchi, our very traditional food, and also instant soups or instant noodle soups. Because when we analyzed the KNS data, what we found was most of the sodium was coming from kimchi and soups and stews for Korean diet. So what we did was, for food industry, we asked them to decrease sodium content gradually, but it didn't work. And in addition to that, some food scientists was helping them by saying, if you decrease the sodium content of the kimchi, we are going to have much more food safety problems because of the low sodium content, something like that. However, the government was able to recruit another group of food scientists who produced the evidence saying that with lower sodium content, the kimchi was still safe enough to eat for weeks, something like that. With that, the kimchi industry joined us in decreasing sodium content, and also for soups and etc. What government did was government asked the meat service industry to decrease the size of the soup bowl, or ask them to have 1 day a week serving menu without soup. So there was a day without soup, something like that. It was Wednesday every month. Anyway, it worked okay to decrease the sodium altogether.
Thank you very much. I'm going to open up in a minute for both the room and also our links community, but I want to ask for quick responses on the issue of low sodium salt. I know in China, this went up to about 26% of all of the salt purchased with perhaps some subsidy, and whether there were any efforts in either of the other countries to promote low sodium salt.
Low sodium salt and condiments. In Thailand, we have these products for quite a long time, maybe 10 years ago, and it's not popular at that time. And after we have the low salt network and mass media campaign, and people more aware of the high sodium and the health effect. So now they are quite popular. We have many products and many companies that produce the low sodium condiments, and it's also will give them a healthier choice for low sodium products in condiments or also low sodium salt, and it's now more and more popular in Thailand.
Yeah, in China, the salt CR is monopoly before, so it is for low sodium salt, the price is almost twice or 3 times than ordinary salt. So low sodium salt, for salt industry, they have interest on promote low sodium salt. But there is another concern that low sodium salt. For potassium, have 25 or 30% of potassium. For kidney disease patient, kidney failure or kidney function patient, they should be cautious on potassium intake. So for public, our policy didn't advertise so much on low sodium salt because we have such concern. But we advertise on potassium, on benefit of potassium intake for blood pressure. And also we advertise the relationship of blood pressure or sodium and potassium. Potassium is related with vegetable and fruit. Also, so we hope to improve awareness of sodium and potassium, their benefit and the risk on blood pressure. Also, we educate the children to let them know what is sodium, what is potassium, what is the sources of sodium and potassium, what is the relationship of sodium and potassium with blood pressure. That is, but simultaneously, the salt industry is promoting the sales of low sodium salt. Actually, the increasing of potassium intake, large part attribute to the low sodium salt sales increasing. So scientists experience in China.
Potassium salt in Korea is not attracting much because the potassium salt gives kind of very strange aftertaste if it's used in soups, because Korean people love soups and our diet includes many different kinds of soups. It was not easy to begin with. In addition to that, when it was introduced like 15 years ago in Korea, the cost of the potassium salt was about triple of regular salt. So it became a kind of luxury item for rich people only. And then not everybody was able to get access to it. And another thing was there was kind of misbelief about the potassium salt, such as because of it has too much potassium in it, it's bad for your kidney, something like that. The government did not take too much action on it because we took advantage of it actually. So we left it there as it is. And also, speaking of the potassium, because we have very, very high intake of vegetable, more than 500 grams per capita per day, we have quite high amount of potassium intake to begin with. Of course, it's a little bit lower than sodium, but it was kind of okay not to worry about potassium intake itself. So we are managing without potassium salt yet.
Thank you, and we'll take one question that we've gotten electronically, and then we'll go to the room, and just very quickly, because it follows on this question, which is, how about the promotion of potassium, because the sodium-potassium ratio is so important? And in this, I will just give a quick answer that sodium reduction will benefit everyone. Potassium increase will benefit almost everyone, but not everyone, because there is a risk of people who have weak renal function that there can be hyperkalemia, which could result in severe adverse events. So we see the promotion of reduced sodium as something that is a good for all. The promotion of increased potassium needs to be done with an asterisk on it. And that makes it a little bit more challenging as a public health program. But absolutely agree with the question that the epidemiologic evidence strongly suggests that not only is low sodium healthy, but the better sodium-potassium ratio, because we generally need to consume more potassium, is even healthier. Okay, Jared.
This is a question to Korea and Thailand. Like you were talking about sodium salt. So popularly people think about sodium chloride. But when you talk about the packaged food, the sodium glutamate, monosodium glutamate, and disodium glutamate, a lot of contradicting articles also appear these days, especially for the growing children. So I just wonder why in many forums, I mean, maybe you meant it or didn't mean it, I'm not very sure, but normally in the forums, they don't talk much about it, but the media and the magazines write a lot about the glutamate salt. That's one thing I would like to learn. Second is, did Korea and Thailand try out the quality testing of the laboratories? You see, like you have gone for a lot of models through the government machinery to control population-based sodium intake. So laboratories, the food laboratories, quality testing laboratories, were they roped in? I mean, was an effort made through that channel also? Because that is also one way of like bringing policy changes.
Thank you.
So for the packaged food, they contain sodium in sodium chloride, sodium monosodium glutamate, or disodium glutamate, as you said. But so we concern all of the sodium salts, every item, sodium glutamate or sodium chloride, we concern all of them. So we account total sodium contents in each package. So yeah. So I think it's the sodium. Oh, okay. Yeah, we include all of the sodium salt.
Yeah, there are sodium from other sources. However, the data I've shown you is from the dietary intake survey, which is connected by 24-hour calls. We are using food compulsion databases, and that database has sodium content of all those processed foods also, which includes, I guess, the sodium from monosodium glutamate or etc., whatever, where it comes from. And also about the second question, I'm sorry, I didn't understand what you were asking. So could you just spell out again? Oh, we are not using label information. We are not using label information. As I said, all the intakes were monitored by registered dietitian interviewer using 24-hour calls. So we are getting all the recipes from home. We have recipe database developed already for restaurant food and meal services, and those recipe databases are renewed every 5 to 10 years. So it is reflecting all the changes in food and even ingredients. So we are not relying on any nutrition label to monitor the intake.
I think you saw from the China slides that monosodium glutamate was a very small proportion of the total sodium intake. Right, so that's one of the glutamates. All right, we have a couple more questions. Let me go all the way to the back, get a little exercise.
Neil Squires from Public Health England. I'd like to ask another question about food labeling. At the moment, we've talked about voluntary labeling, but should we be calling for compulsory food labeling and the level of detail we'd like to see on that labeling? So do we want to see the percentage daily allowance? And do you think we could make a very general recommendation about requiring all processed food to have detailed healthy information, including percentage daily allowance, as a campaigning tool? Clearly, for the Framework Convention on Tobacco, we had very clear rules. The problem with voluntary codes is they don't go far enough. People either take them up or don't. And we're not giving clear and consistent messages to consumers. So can we be stronger?
And I'm going to walk slowly to the front while I give one answer to that question. The best we've seen from around the world is from Chile, where there's a mandatory warning on high sodium foods. And that has resulted in about a 1/3 reduction in high sodium foods in just over a year. So there's a potential to use warnings as a way of shaping the market. But the question is specifically about the nutrition facts label and the percent of the daily requirement and whether that's required and can be a useful approach.
I think so, but in Thailand we we use the GDA labeling on front of packs about 5 categories from the FDA regulations, and next year, I think FDA told me that they will expand to more than 20 categories of the food products. And so the FDA, the GDA will be on the front of the pack and which will clearly visible. But for the other, we have done spot checks for some other products which they apply for healthier logo by the Institute of Nutrition, Hidon University, and they will if they are not very accurate, so we will send the data to FDA to give the warning or apply the or law enforcement.
So in China, we have legislation on food labeling, including the sodium content. But the challenge is just Tom mentioned the warning, the high sodium. What is a high sodium food and low sodium? So that is the traffic light labeling system. That is a challenge to provide information for the public.
In Korea, yes, we do have sodium and everything else in nutrition label, but personally, I don't think that putting sodium content in nutrition label is working not anymore than just increasing some awareness on sodium intake, because the sodium is coming from almost a billion different sources other than processed foods in Korea, because we use them as soy sauce while we cook dishes and etc. So I think although it is there, and also some people are getting some information about sodium, their sodium intake, I don't think it's as effective as like putting trans fat on the label.
So we have exactly 5 minutes left, and we have at least 3-4 questions. We're not going to get to all of the answers, but I thought it would be nice just to raise those questions, and then we'll answer 1 or 2 if we can.
Okay, thank you. I'm Paula Jones from Brazil. I really was very happy to hear that Tom mentioned the example from Chile, and I think we should have more south-to-south exchange of like what to do with regards to labeling, because I think the GDA, it's not the best model according to the evidence that we have available. So I think I'm really happy about it. And I would just say a comment on the warning. I think we could have, I mean, thinking about the tobacco example and so on, we could have like a good side effect if you put a warning label about high in sodium for people becoming aware that sodium and salt, it's not such a good thing, that you should pay attention to that when you prepare your own cooking food. So I think we could have some good ones. And just a quick question for Thailand on the healthier logo, whether you have thought about any like undesirable side effects of putting a healthier logo in processed foods, whether you have thought about it. Thank you.
Thank you. We may have to have the questions answered in the break, but we'll at least have them raised now.
Yeah, thank you. I'm Rupa, I'm from India, and I have an exactly contrasting question. In India, most of the food which is eaten outside comes from the unlabeled, and unregulated market, which do not have labels. And I want to hear from the panelists, what has been your experiences in reducing sodium in that sector?
Very quick question.
Thanks, Anselm Hennis, PAHO. Basically, just to take up the point about Chile and front package labeling, what it does, it actually affects choices at the time of purchase in a very significant way. And secondly, a number of companies have actually reformulated their products, as many as 17%, to actually offset the decrease in sales due to consumers being empowered by the knowledge due to front package labeling.
So it changes both choices and options. Last question.
Hi, I'm Jamie Hussain from CDC, working as an economist. Trying to understand, there has been a long-standing campaign for iodine salt use, and over a quarter of the people, 1 in 4 people in the world. So for some part of the world, it's an important vehicle. So trying to understand whether there is a conflict of or possibility of mixed messaging.
The key there, I can answer that while I walk to the front, is to coordinate. That as sodium consumption decreases, the concentration of iodine would have to increase to adopt it. Now that has left us 3 minutes for the questions. Can we have those first a question for Thailand? Did you want to try to answer that very, very succinctly?
So there are many questions.
Choose one, anyone you want.
Okay. So ask about the side effect of healthier logo, right? I would say that the healthier logos for some products, the criteria of the criteria of sodium content is still a little bit higher than the average. So because at the beginning, the industry want to reformulate a little bit slowly. So they try to reduce sodium a little bit, 10% or 15%, and they argue that they can get the healthier logo. So we, at the first year, we quite relaxed criteria. So the sodium content is still sometimes quite still high for the healthier logo in some countries. So the consumer may misunderstand that this product is healthy, but it's not healthy. It's healthier than the other products in the same categories. And I think this is one of side effects.
For those food other than processed food, because of the increased awareness, people are asking for lower sodium version whenever they eat out. That makes the difference. It is impossible to monitor by labeling or anything.
Okay. So thanks to all of our panelists for really interesting presentations. We heard substantial progress from Korea. Not only did they meet their target, but ahead of schedule and saved $11 billion. We heard from Shandong province an example of working both to increase potassium and reduce sodium through a comprehensive government approach that involved mostly non-packaged food, mostly prepared foods. And through Thailand, the beginning of a very focused effort to get progress, and we hope to get a tax on high sodium foods in the coming years. So thanks to all very much for your efforts and for being with us today. Thank you. $420.
in about 2 minutes. Okay. Hi, everyone. It is 4:20, so I think we're going to get started. If you could please take your seats. Yeah. Okay, everybody, please take your seats. Dr. Jaffe, please take your seats. Sorry to call you out, Mark. Okay, great. Hi, everyone. Thank you so much for coming back and sticking with us for the third panel. These have been really exciting discussions so far, and I'm really looking forward to this one. My name is Laura Cobb. I am the director and the lead for nutrition and surveillance for the Cardiovascular Health Initiative of Resolve to Save Lives, an initiative of Vital Strategies. Next slide. So in terms of trans fat, artificial trans fat elimination is proven to save lives and is easily achievable. It was first done in 2003 by Denmark, and it's now been implemented in over 20 countries. You can see on the graph to the right that after Denmark implemented the law, deaths fell by 3.2% in Denmark compared to other countries in the EU. And additionally, in Denmark, switching to healthier alternatives did not increase the cost of food, make food taste different, or prevent specific foods from being manufactured. This panel session will highlight countries and regions at different stages in the TFA elimination process and also explore regional approaches to trans fat elimination, particularly thinking about Latin America and the Caribbean. This panel follows on WHO's launch in May of the Replace Action Package and the commitment to make the world trans fat free by 2023. And we've been really excited to partner with WHO as part of this. The Replace Action Package provides tools and tips to countries to eliminate trans fat and a sort of set of 6 key steps, including review sources of industrially produced trans fat, promote the replacement of industrially produced trans fats with healthier fats and oils, legislate or enact regulations to eliminate artificial trans fat from the food supply, assess and monitor trans fat content over time, create awareness of the negative health impact of trans fat among policymakers, suppliers, and the public, and finally, E, enforcement, so actually ensure that there is compliance with regulations once they are passed. Next slide. So the objectives of this panel are similar to the others, but just to say, to provide tools and proven actionable strategies to include cardiovascular health at the country level, to highlight successes and lessons learned from the field in areas of artificial trans fat, and to inspire action to address CVD, which, as we all know, is the world's leading cause of death. Next slide. So this is our trans fat elimination panel. I will be moderating, and I'm very excited to introduce our panelists. Dr. Sohail Chowdhury, a professor and head of the Department of Epidemiology and Research at the National Heart Foundation in Bangladesh. Dr. Anselm Hunnis, Director, NCD and Mental Health at the PAHO. And Dr. Vizith Chavazit, Professor at the Institute of Nutrition at Mahidol University, Thailand. Thank you all very much. And I think we will start with Dr. Chowdhury.
Oops. Thank you, Laura, for the introduction. I'm going to talk about the role of civil society in Bangladesh to start the policy action for elimination of trans fat. And I work for National Heart Foundation of Bangladesh, which is an NGO, and have been working for cardiovascular risk reduction through health promotion. So to start with about the cardiovascular disease burden in Bangladesh. Bangladesh, as you may know, is a low middle income country in South Asia with a population of 165 million, which makes it a almost mostly dense populated country in the world. And we are going through the epidemiologic transition that we talk about. 67% of all deaths are due to non-communicable disease. And cardiovascular disease is the highest proportional mortality. Almost 30% of deaths are due to cardiovascular disease. And most important thing is we have large number of premature death. Among the non-communicable disease, 22% are actually premature death. We have very extensive data on several cardiovascular disease risk factors in Bangladesh. We did some large-scale survey like STEPS, GATS, etc. So we have 21% of our adult population have hypertension. We have very high prevalence of smoking, both smoking and smokeless cigarette, and high salt intake is there. But there are very little data or information on trans fat intake or situational or policy regarding trans fat in Bangladesh. And we have, as I have told, National Heart Foundation of Bangladesh, which is a non-profit, non-government organization, we have been working for tobacco control and also for salt reduction in Bangladesh. And recently we took an initiative to bring this trans fat issue to the table, on the table of our policymakers and other stakeholders. So with the help of a grant from Global Health Incubator Initiative and also Campaign for Tobacco Kids, for last 3 months we have been working on this trans fat issue. And we did, in the beginning, we did a situation analysis of Bangladesh, trans fat issue in Bangladesh. And we actually analyzed the policy environment and the legal environment that can help us to work for elimination of trans fat. In the policy environment, we found that our national nutrition policy and also guideline of 2013 actually recommended about control of trans fat intake, but there was not clear-cut roadmap or strategy was mentioned in that. And also our policymakers are not much sensitized about the trans fat issues and the relation of trans fat and health for reduction of cardiovascular disease. And also in our legal environment, we found that recently government has established Safe Food Authority, who has actually legal mandate for formulation of law, any regulation that has impact on health. So we can utilize that mandate for formulation of formulation of regulation. And also Bangladesh Standard Testing Institution can enforce this regulation if the policy is there from Safe Food Authority. So next slide, please. Okay. So from the recommendation, we actually, from the situation analysis, we have some recommendation, like we can use the good policy and regulatory environment that we are prevailing in country, and the technical committee of Safe Food Authority may actually recommend such regulation. But we need some research on TFA exposure on population, because for development of policy or any regulation, they actually, I mean, our regulatory authority need some data from our own country. And we also, while we are reviewing the situation, experience of different countries, we found that the regulation, the pathway that India took, that is gradual elimination process, might be applicable to Bangladesh situation also. And our TFA regulation should be a part of overall program of NCD control, because recently government has agreed to do a multi-sectoral NCD control program they have started, and TFA regulation should be a part of that multi-sectoral program. Next slide, please. So with a view of engaging community, we actually started training our journalists. So in December, we organized a workshop for journalists for training them about transfer issue, and that was an interesting one-day workshop with media personals from different media group, and that was widely covered in the news. And as a result of that, the issue of transfer actually was raised in different forum. Next slide, please. And then we started to advocacy with high-level officials, because National Heart Foundation National Heart Foundation is very, has a leadership role in NCD prevention in Bangladesh, and we could easily convince or access our high-level policymakers. And so we actually met different head of different ministries and standard testing institution and food safety authorities. Next slide, please. So our future plan is to continue with the engagement of community through journalists and civil society. Also generation of evidence of TFA level in local foods. In this regard, we have actually secured a grant from government to measure some TFA content in deep fried snacks. And also we need to do mapping with our food industry, what we plan to do in next few months. And we'll continue advocacy with policymakers for formulation and enforcement of regulation. Thank you.
Thank you so much, Dr. Chowdhury. We're going to move to our next panelist, Dr. Bizith. I'll bring you.
Good afternoon. This part I will tell you about the experience that we have done about the trans fat in Thailand. And right now, from January the 9th, we have announced Thailand to be trans fat-free country. Okay, so let's see the step that we were working on. In fact, we in that notification, right, we prohibit the production, importation, and distribution of PHO, nothing to do with trans fat. Okay, and the products in Thailand. Okay, and the compliance is if they still use PHO in their products, they're gonna imprison from 6 to 24 months or fine from $150 to $600. In fact, before we start, we have situation analysis about 10 years before this. In the last 10 years, the issue of trans fat have been raised because that time Thai FDA want to have a trans fat on nutrition labeling. So we want to see that it's supposed to be there or not. If we put in there, will people confuse between trans fat and saturated fat? And if trans fat becomes zero, people still eat it because they thought it's safety, right? So we did the survey and we found that trans fat is not the big issue in Thailand. It's only in the food for the low and the high and medium income people, because it's spread in the bakery products, most of them. And most of them are influenced by the Western eating culture. For the lower income people, they use the natural saturated fat, for example, palm oil and coconut oil. So in this case, we inform FDA that don't put it on the label, because people will see that, okay, trans fat really low, but they don't look at the saturated fat, they're gonna be confused. That time we stopped the program, and then we keep monitoring a little bit until US announced that they're gonna ban trans fat in the country. We think that we do trading with US. If we don't do anything with the trans fat, the products from US may come to Thailand, because we did a lot of trading with US. So that time we start to do the situation analysis seriously again. And we found that the same group of the products still have trans fat in there. So in that way, we did the survey and then we talked to stakeholder to see the opinion. What are the stakeholder? The first one is the oil production, the oil producer. Oil producer, we found that in Thailand, only 3 plants that can do hydrogenation. So we tell them to stop if they can do it. Okay. Second one, the second part is the user. User is food producer. The food producer, we ask them if they can find any replacement. So the oil producer said that they can do the replacement because they can do the process of oil blending. Oil blending is easy for this part of the world because we have a lot of saturated fat. So if you use like a palm oil from the seed, it's very saturated. If you mix with the soybean oil or rice bran oil, you can get the texture that you want. So you need to do R&D. So they said they have to do work together. So this is the second stakeholder. The third one is the importer, both oil and food. We have to say that you have to inform your supplier. We don't want it to be in our country. And the fourth one is the regulator, FDA. FDA play a really important role because they have authority, so they can call all stakeholders to come to the meeting. We don't have any power. So this is the part that we work together for years. We try to find a way out. And then after that, after we are sure that only some of the producer or the oil user that hesitate not to change because of the notification hasn't come yet. So we decide to have the notification out. And after that, we have public hearing. Okay. So, so in this case, you can see that the strength is we monitor the situation critically, and PHO is not go down into the low income people, right? We have a local funding agency that provides the funding for the whole process, and our location is easy to find saturated fat, and then we don't have so many oil processing plants in the country. The next one, sorry. Oh, okay, yeah, and the industry have the capability to do the product development, and analytical lab is available. And we also export to many countries that trans fat has been banned, so the knowledge have been there, right? And then so we have been prepared before the change. And then, okay, the regulator is ready to help us. And then, okay, we have, the last one is we cross linkage between working group and consumer protection organization. So both sides working together to monitor the products in the market. Okay, the challenge that the knowledge is not go down to many parts. So a lot of drama in the media until the law have been implemented. And sometimes you have a false positive analysis in the lab. So the result come out to be overestimate in terms of the situation. And so this is, we have the regulation to block PHO from developed country to come in. And also sometimes we get the problem with the multinational company that they don't want to join with us, okay? But now when we have law enforcement, they have to do, okay? And the fake news from the social media make the people become aware and then become scared that they don't have the raw material to do their business or something like that. So that is a problem, but we already solved it. Okay, yeah. So the key factor for the success, communication, openly, sincerely, and respectfully. Fully support and commitment from the regulator, technical strength of the local producer, strong scientific knowledge and evidence used for supporting academic, technical, and regulation process. Ingredient and process of choice are available, accessible, and affordable. And the last one is the 5P, public, private, professional, and people partnership. Yeah, okay. This is a one that I think we did it successfully in this case. Thank you.
Good. Well, thank you first of all to the thank you very much for the kind invitation from the sponsors who've invited us here to participate. I'm going to speak a little bit about Trans Fat Free Americas, the initiative that we have ongoing in the region of the Americas. Now, Now, basically, approximately 160,000 of the global 540,000 or so cardiovascular deaths, which related to trans fat consumption, which in 2010 took place in the Americas. It accounted for 18% of such deaths in Canada and the United States, and about 12% in Latin America and the Caribbean. Now, although Denmark, as you heard, was the first country to really institute banning of trans fats and full elimination, the region of the Americas moved rapidly soon thereafter. And in fact, in 2003, the US introduced mandatory nutrition labeling, which came into effect in 2006. And in 2007, as you all know, Mayor Bloomberg led efforts to ban trans fats in restaurants in New York City. And this whole process was rapidly disseminated throughout the United States of America. In 2007, the Pan-American Health Organization established a working group, Trans Fat Free Americas, which proposed a number of recommendations. And these included the fact that industrial trans fats should be eliminated from food supplies in the region and replaced with unsaturated fats as an alternative. It proposed government regulatory actions in addition to the voluntary efforts of the industry. It set limits on trans fat levels. It recommended measures that governments should consider to include mandatory labeling of trans fat content in foods, among others. Also, that advocates should work with the industry to speed up the phasing out of trans fats. In addition, governments were supposed to provide support to restaurants and manufacturers to eliminate trans fats, which is a group which is often forgotten. This work continued, and in 2008, this led to the Declaration of Rio de Janeiro, which is the Trans Fat Free Americas initiative. Thanks. Now, we are now 10 years out from the Declaration of Rio. What has been achieved? Basically, regulations are in place in 8 countries in the Americas, with Canada coming on board last September with a phase-in period of their regulations. Now, in line with Denmark, which established a limit of 2 grams of trans fats per 100 grams of total fat or oil in all foods, this criterion has been adopted in the Americas by Chile, Ecuador, and Uruguay. Peru, Canada, and United States use the model which bans the use of partially hydrogenated oils or PHO, which is the main source of industrially produced trans fatty acids. Now, Colombia and Argentina use slightly different models, but the first which I discussed are in fact probably the more desirable models, and ultimately want to see the full banning of trans fats. Now, you heard from Dr. Cobb about the launch of the Replace package in May of 2018. This took place in Geneva at WHO headquarters. In the Americas, we're in a slightly different time zone. So as soon as we woke up, we got on with our activities and we launched the Replace package in the Americas that same day. And we actually were able to use a video from WHO, etc. And we had countries such as Argentina and Panama sharing their country experiences. Good. Now, at our Directing Council, which is the regional meeting of the Pan American Sanitary Bureau, last September, we had a side event which showcased the importance of a Trans Fat Free Americas initiative again. Panama and Canada shared the experiences, and you will note, if you can see it on the screen on the far side, on the left side, es hora de actuar, and this really is time to act, which basically led then to the resolution at the Directing Council for the elimination of trans fats. Where are we now? It's 11 years on, and we did not progress to the extent we thought we would progress. And first of all, this plan of action that we now have is going to commit countries to implement a mandatory elimination. Secondly, the Declaration of Rio had no accountability built in. The plan of action does this now in turn. And the plan should catalyze enactment, implementation, enforcement, education, and monitoring. Excellent. The strategic lines of action are enactment and implementation of regulatory policies to eliminate trans fats from the food supply, enforcement of trans fatty acid elimination by defined and implemented enforcement systems, assessment of the progress and impact of TFA elimination in local food supply and in human consumption, and to create awareness of the negative health impact of TFA among policymakers, producers, suppliers, and the public. Thank you very much for your attention.
Thank you all. Thank you so much for your presentations. So we have about 25 minutes for questions. And I wanted to start, before we open it up to the forum, I actually wanted to start by calling on Paula Johns. If you could comment as an advocate and from the lessons that you've learned working on other health issues and nutrition issues, how would you want to apply those to trans fat elimination?
Hi, thank you, Laura. Well, again, I'm Paula Jones from Brazil. Just one comment about from evidence to implementation, how long it can take. We saw just the example from Latin America, just from the declaration from 2008, and I mean, not that much has happened. And on the other hand, when you look at Denmark, and I remember listening from the health authority, the Danish health authority, oh, how did you do that in Denmark? Oh, we had the evidence and we did it. But I think Denmark is a very special country. I lived there many years, so I can say that you have like this really wonderful combination that evidence becomes implemented into policy. This is wonderful, but that's not what happens in most of the countries in the rest of the world, unfortunately. It takes too long time before we do what we need. We know that needs to be done. It takes far too long time, like, to make it real. It's just like in the case of, I think in the case of some places, I think it's good to have like this deadline 2023, because that's a real big push for advocates at the national level to work with that deadline, to push for it. Doing like my own, what we do in Brazil, and I mean, this is not in our priority list, or it was not in our priority list at all, because we approach food like more in the term regulation of food, more in terms of like, okay, we want to promote people eating real food, and our agenda around healthy diets, it's very much based on the Brazilian food guidelines, which it's all about eating real food and not so much diverting all the attention into how we can reformulate products to make them less bad, as they're not good in itself, right? Because we are talking about a category, mostly about a category of products that we are not recommending people to eat in the food guidelines. So it's in our perspective is a bit of a diversion of what we should be working on. But I think it's very welcome that you invite advocates to put this push on that particular issue, because I think that's an easy one. I think if you have advocates working for that, it can go really quick. So I was thinking about like in Bangladesh, in Brazil, we have a regulatory agency who will have the mandate to do that, but they are just too slow. And I think political will, it's a key sentence here. And I think Thailand seems to have a lot of strong political will for many of the important measures that we need to take. And in many countries, I mean, I think this is a very hard issue right now. In Brazil, it's a very complicated issue. The political situation there is really not good at all. And in many of the other Latin American countries, I think we're facing some of the similar challenges in terms of like the turn that politics have taken on this last year. But I think that's a key one, and I think it's it's an easy one in a way. Trans fat, it's an easy one, and we should be able to do it by 2023 if we have enough advocates working on that. And my question, I mean, I think thinking about a little bit about the panel, what kind of barriers, why does it take so long from evidence to implementation? I would leave that open question. Thank you.
Thank you so much. Does anyone on the panel want to take that question? Why it takes so long from evidence to policy?
Sorry for you looking at me, Laura. Yeah, I think really it comes down to a lot of factors that drive the change from evidence to policy. A lot of it comes down really to an empowered society. Political will, again, tends to respond to an empowered society. So we have very powerful advocates who make the case. I mean, look at New York City. When Mayor Bloomberg is also the ambassador for health, for NCDs, for WHO, when he led the move to eliminate trans fats, he got it done. He was a very powerful advocate. And I think, therefore, I think there are examples that we can look to and learn from. And various other countries have also had strong leadership in terms of driving it. So evidence is necessary, but it is not sufficient.
In my opinion, I think it depends on the level of the the seriousness of the problem, because from the evidence that you have maybe show differently. In case of Thailand, we feel more relaxed because we found that trans fat or PHO have been used only in the cuisine or the diet that is not really traditional one. So when you go down to the lower market, they don't use it. So it's just something that in the Western style. And another thing is so in terms of the quality, that change maybe not so much effect in terms of acceptability because we are not used to, or we used to, but we not know the authentic one. And the technique oil blending, in fact, it's very old technique. It has been used since Napoleon period, right? Napoleon used it for making margarine. So if you find the right oil or fat to mix together, you can get a lot of variety of kind of fat that you want. So this is the thing that I think you need to have R&D, and also think that, and we are the country that export the food. So when you export the food to the country like a US that ban for the trans fat, industry have to struggle to be survived, I guess.
Well, I just would like to add the perspective from a low middle income country regarding this. I mean, we have other more competing issues to address by government. I mean, we are actually, infectious disease was a very big challenge out that, and that has been overcome by concerted efforts by government and our UN organizations and other development partners. Now we move to NCD, but still there are some other bigger risk factors that government, and we were actually pushing government to act on, like tobacco control, blood pressure control, salt reduction is recently added. And the trans fat issue was really that was not addressed in our setting. So we have started probably, and let's see with the sharing of our experience, how can we move?
Thanks so much. I just we got a question from the online forum, which was, how can we measure trans fat in restaurant foods? I don't know if this is something that any of you have thought about.
This is the issue that for for analysis of trans fat is not easy, because you have cis and trans can come on the same peak if you don't have the good columns in terms of the GC or whatever. So in my presentation, I talk about the false positive. In some laboratory in Thailand, the situation of trans fat become overestimate because they did the wrong analysis. So based on the USDA, I think right now you have to have like 100-meter columns in order to separate between trans and cis. And also you have to have a good standard for the trans in order to detect all of it. So this is the thing that's why when we draft the law, we try to stop at the initial stage from the producer of the source, not go down to analyze the trans fat. Trans fat can be used for monitoring. For example, you know that, okay, this bakery products, normally they can use trans fat before, so you monitor it. Or if you monitor it, for example, one serving, based on the WHO, right? In one day, you should not have trans fat more than 1% of the total energy. That means it's about 2.2 grams per day or 0.5 grams per serving. So if you have trans fat more than 0.5 grams per serving, it means that is a health risk. But from our study on the risk assessment, none of the food that we found in the market over than 0.5, if they don't use PHO. Even butter, one serving 15 grams, you get about 0.5 or 0.6 only. But for butter, you can use the standard from Denmark or from Europe, that 2% trans fat per 100 grams of fat. That one can be can adapt. So in this kind of standard that we use from the WHO or from the other country in the developed country, you can adapt in terms of monitoring, but we will not control as a trans fat because the cost of analysis is so high. We control as the producer of the PHO and the importer only.
Okay, thanks for that. I just had a very quick answer to that question as well, which is a little bit different. So one is if you control the importation or the production, then you don't have to worry about it at the restaurant level. The other issue, what happened in New York City when New York City banned trans fats in restaurants, was that they were able to rely on the fact that the US had already passed labeling legislation, so trans fat was labeled on packaged foods. And so the restaurant inspectors were actually able, when they did food inspections, to look at the foods purchased by the restaurants, the oils, the packaged foods, all of that, and to check that restaurants were not purchasing and using any foods that had more than 0.5 grams of trans fat per serving. And so that was a very different way, and it required a lot of infrastructure already in place in the country, including mandatory labeling. So New York was very lucky to have that to build on in order to do its restaurant regulation. Anselm, did you want to add? Okay, great. Fantastic. Can I open up Rupa?
Thank you. My question is to Dr. Vasit. You mentioned that it's the products in Thailand, which is used by the middle and high income countries, high income groups of society. Unfortunately, in India, a lot of bakery products which are high in trans fatty acid are used by low and lower middle income groups. So cost becomes the major factor there. So my question is how easy or difficult was it for the bakery manufacturer to move from the PHVOs to the blended oils? And was there any cost implication to it, or did they occur any losses in terms of businesses?
Thank you, Rupa.
The problem in India, I think it's harder because you go to the grassroots already there, and that I used to it. If you look at the partially hydrogenation process, I am food scientist, I think it's brilliant, very brilliant process, because when you do the partially hydrogenation, you want to produce something to imitate costly animal fat, for example, butter or lard, or even your ghee, right? Or even the cocoa butter, you can imitate it. You use one machine, you use one kind of oil, and you change the condition. You try to use very polyunsaturated, and then you put hydrogen to one position, you get one oil. You put another two position, you get another oil. So if you use mathematics like a combination, permutation, you get hundreds of products come from one kind of oil with one machine. So the cost not so expensive at all. You can play around with the most expensive oil or generally use oil. So if you change the process that the oil blending, you need to do R&D, research development. In terms of the like a bakery or deep frying, they look at the like they call solid fat index, that you have to mix between saturated and unsaturated at different degree to get the products of different degree. Not so easy, but they can do it. Sometimes you get something that the last product that we try to let them stop using PHO is fried donut. Fried donut, when you fry it with the PHO, you get the donut that come out crispy, but not wet. And then you can coat with chocolate, with sugar, and then stick on it. And when you touch on it, it's not wet. And you have some smell of soybean a little bit. It's not easy, but sometimes consumer have to accept it. When you change the acceptability, you know, sometimes at the beginning, one company want to change it. They said that the first batch that they sell about 1 or 2 tons return to the company. Cannot sell because people are used to that taste. But you have to let them learn on it. You know, you need them to do R&D, and the mix between the tropical oil and some other oils gonna be the one that you can use later. Yeah, but you have to try it. Yeah. Yeah, the cost should not be so much different you know, because the process that you use, right? Normally the tropical oil is cheaper than the oil from temperate, so you have to mix it. Yeah.
Thanks. Do we have other questions from the crowd? Well, if we have more, I have a question, which is to ask about the response and the role of industry in trans fat elimination. Particularly, perhaps we can start with the response of industry in Latin America.
Yes, well, as I demonstrated in my presentation, industry all signed on in 2008 to the Declaration of Rio to eliminate trans fats. Industry is a key player, and they must be engaged and they must work with the health authorities and governments, etc., to resolve the problem and to eliminate trans fats from food production. So their collaboration, cooperation is critical. The challenge that tends to be seen is that because of the challenges that industry faces, the example which you just mentioned, quite often the targets that are set are not met, and they extend into perpetuity. So ultimately, self-regulation has not been a successful model. Therefore, the 8 countries that we have demonstrated in the region of the Americas that have eliminated trans fats have done it through regulation. So regulation works, that we know for sure. But even though regulation works, industry also has to play a role, because they have to then change the products. There will be costs that have to be incurred at one point in time, a one-off major cost, whatever it is, but industry has to be collaborating and cooperating for it to take place. So industry is a major partner, and without the cooperation of industry, you cannot achieve it. So there has to be a negotiation to achieve the endpoint in the interest of public health.
I agree.
Yeah, I think so. Yeah.
Great. Another question that I have, something that's come up a lot in terms of trans fat elimination, is enforcement of regulations. And Dr. Visith, in another presentation of yours, I heard you talk quite a bit about Thailand and how you're planning to enforce the regulation. It would be great to hear about that from you, and also Dr. Hennis, to hear from you about your plans for enforcement as part of action moving forward.
So the first step right now is to stop the production of PHO. Since we have only 3 plants, you have to know in your country that how many plants you have first, and you talk to them. You cannot 100% stop, because PHO also used for other application. So normally we have in food industry, we have the food grade lubricant. That food grade lubricant have to produce from the oil from plant or from food, you know, because you use in food industry. So you have to allow them to use the food grade to produce the food grade lubricant. But for other food you are not allowed. That one only the lubricant only, and that one you can stop in terms of the domestic supply. In terms of the importation, you have to talk to the importer that you're not allowed to have this one. So by checking COA, certificate of analysis of the products, is important that they have to guarantee that they don't have. Normally you cannot have zero trans fat, because in the process of, for example, you know that in the ruminant you have trans fat naturally, and butter is the one that the butter oil is the highest one, should not be more than 6%. This is the one that you know the number. For the process of refining vegetable oil or cooking oil, you need to have the process of you call deodorization, that you have to heat them until 200 degrees Celsius for a certain period of time. You get some trans fat, but not more than 2%. So in this case, you use that one standard for checking the fat that they use in the industry, the fat that you import from other country. Otherwise, in terms of monitoring, you can sampling. I mean, the sampling plan in my country is easy, because we know that most of them are bakery products. So we're sampling and check if the trans fat, this is trans fat now, more than 0.5 gram per serving. That one we suspect that it should be come from PHO. Yeah, this is a way that we use to monitoring and regulate. Yeah.
Yes, thank you very much. And just to add to what Dr. Visith said, basically there are guidelines and frameworks for ensuring compliance. And these include, for example, establishing and implementing mandatory and voluntary quality management systems. So they are sophisticated. And the process includes things like inspections, audits, verifications, grading analyses, sampling, and feedback to the manufacturers and to the restaurants and so forth where products are manufactured. And then there's and these are frameworks which are developed and used in Canada and by the FDA. And these really are best practice standards. And I think this is sort of framework that we will be encouraging countries to develop or similar frameworks to this. So there are very definite models that one can use to ensure enforcement and compliance.
Thanks. I think there's time for one more question. If there is one more from the floor, please let me know. Otherwise, what I would like to ask everyone before we close is if you had one piece of advice for countries looking to eliminate TFA, what would it be? And I'm interested in that from all three perspectives. So Bangladesh, you're just getting started in this process. You know, Thailand, you've just completed it. And you know, for PAHO region, we have sort of a mix. We have some countries which are really all the way there and others which we're hoping to gear up for more legislation and enforcement.
Well, since we have just started the process, I think for the countries which are at our stage, we need a strong civil society movement to press on the government and also the industry to take this issue seriously and move on. So at this stage, I think that the leadership of a civil society organization, maybe a physician-led organization, could be very helpful for moving it forward.
In my opinion, I think the first step is to communicate with the stakeholder. I have to use the term sincerely, respectfully, and then you will get something out from the industry. They will tell you, because many things we don't know. We are not in there, but they are in there. They do the trading, they do the communication with their customers, so they know, and then they will tell you. So I think the first step, you want to know situation in depth, not just analysis, but you have to talk to them that what is the problem, what is the burden, that if they have to do this one, what they need for what help that they need from us or something like that. And this is a part that I think very important. After that, things will come smoother. But if you don't openly talk, it's not easy.
Thank you. And just to add to what my colleague said, the evidence that trans fats, industrially manufactured trans fats, are harmful to health is unequivocal. Our grandmothers baked and cooked without the access to trans fats, and we are none the worse for it. So therefore, we don't need industrially produced trans fats in our diet. So therefore, we know that the process must be to eliminate them totally. The processes exist, and really, we know that regulation works. So it really is a matter of evidence to action, as we discussed at the very beginning. And as I showed Minister of Health from Panama, es hora de actuar. Now is the time to act.
Oh, okay. We have one question from the floor. Anupam?
Thank you, Laura. Besides replacing trans fats with a blend of oils which would contain saturated oils, are there any healthier options?
I can answer that question a little bit, but one thing is it depends on what you're trying to do. So if you're trying to fry or deep fry, you can use healthier options. You don't need a lot of saturated fat. For some of the bakery applications where you need something solid, it's hard to eliminate the saturated fat from your replacement. However, with blended oils, you can try to get the blend to have as little saturated fat as possible to meet your needs. And so that can hopefully, ideally what we're looking for is replacement of trans fat so that the total trans fat plus saturated fat goes down over time. And you're going to see a little bit of a rise probably in saturated fat, but together the total unhealthy fats should go down in the products. Dr. Vizith.
Just take one. I think the no good oil or bad oil. I think only appropriate oil. So if you want to do the deep frying, unavoidable, you have to use saturated fat, but you have to minimum the consumption. Not, I mean, if you can calculate, not more than 10% of the calorie, you know. But deep frying, if you don't use saturated fat, you can get free radical if you use polyunsaturated. But you use polyunsaturated or monounsat as much as possible. But the diet, you know, traditionally by culture, sometimes you cannot avoid. So you use it, but you minimum the eat, I guess.
So I just wanted to summarize the panel. I think our panelists have done a great job of talking about work in different areas. And, you know, there were just a few things that struck me from what they've said and how that resonates with what we've heard from other places. So from Dr. Chaudhry about Bangladesh, there's a need to have data on what trans fat looks like in the food supply. And that's something that we've heard not just from Bangladesh, but from many places, that there is appetite and interest in taking action, but that policymakers would like to see data. So I think that that's something that we just have to consider and think about as we move forward, that gathering data, gathering the evidence is really crucial, though as we've heard, it's not enough, right? But it is critical. One thing from Dr. Vizith's presentation that I thought was really interesting, and which has been mentioned before in terms of Thailand, is that while the trans fat levels in Thai food was relatively low, there was a concern that as developed nations, US and Canada in particular, were banning PHOs, that companies would be potentially dumping those in other countries. And so there was a concern that this might go up over time. And then finally, you know, I think from Dr. Hennis's presentation, the potential of regional efforts is really exciting. And while the first iteration of Trans Fat Free Americas didn't end in full elimination, the number of countries in the Americas that have legislation is very high compared to other regions. We're talking about 24 countries already that have the proper elimination implemented and on the books, and I think 8 or 9 of those are from the Americas. So, you know, that's a third, and the Americas are not a third of the countries globally. So that is very important, I think, still. All right, well, thank you so much. I think I'm going to invite Dr. Frieden up to give some closing remarks, but can we just give a hand to all of our panelists?
Thanks to all 3 panels and to the audience for really interesting and involved questions. If we step back and think of the big picture, there is an urgent need to scale up prevention of cardiovascular disease globally. We have really good information. We know what needs to be done. We have to learn more about what more could be done or how it can be done, but a lot is already known. And the biggest challenge right now is to close that implementation gap. And one of the best ways to do that is to have sharing among countries that are working on this, that we can learn from each other, learn from both the successes and the failures, frankly. I had a teacher who once said that he wrote up his mistakes because he wanted other people not to have to make the same mistake. There's no shame in attempting to implement a program and rigorously evaluating it and finding that it doesn't work. There is shame in implementing a program and not checking to see whether it's working. And so what we encourage is an open discussion. Linkscommunity.org is a way that we hope all of us will be able to share lessons. We were just, thank you, Abhishek, we just got permission from India to post really interesting PowerPoints there. It'll be a resource for people from around the world. We already have hundreds of people from more than 50 countries involved, and we hope this will be one great platform for South-South sharing and for global sharing as we all work together to see how can we prevent those millions of deaths that don't have to happen each year. So thank you all very much.